Hello, my name's Buch. I'm a professor of rheumatology at the University of Manchester, and I'm really pleased to be contributing to this session. The talk I'm going to give today is going to focus on difficult or refractory rheumatoid arthritis. So these are my disclosures over the last 12 months. I'm going to start actually by asking a question that I'd be grateful if you could all complete. And it's listed here. What do you understand by refractory rheumatoid arthritis? And I've given 5 options here as listed. RA complicated by extra-articular disease and or multimorbidity, or the need to try a different number of drugs. And I've listed whether this you feel would be due to toxicity, inefficacy, a combination, or indeed any other reason. So I'll give you a few moments to complete that. Okay, so the concept of refractory disease in itself is not new, and certainly in rheumatoid arthritis has been talked about since probably the start of this century. And I've highlighted an article here approximately 16 years ago that detailed refractory rheumatoid disease that had been unresponsive to conventional therapies. And certainly it's now emerged also, and hence the focus of the talk today, in the era of advanced therapies. Conceptually, refractory disease refers to the resistance of multiple drugs that have different structures and mechanisms of action. And so if we focus on this area, you'll note that the title of the talk was also difficult to treat. And certainly these two terms have been used synonymously. The purpose of this slide is perhaps to illustrate that difficult to treat encompasses a broad umbrella, as it were. And I've included here various factors that influence our decision-making every day, irrespective of the number of drugs that individual patient may have tried. So we're all aware of patients that may have particularly poor prognostic factors that might encourage us to be more responsive and aggressive with our treatment approach. We see patients that also have toxicity to drugs, or where there may be a suggestion of immunogenicity to monoclonal antibodies. With an aging demographic and and multimorbidity, certainly treatment options may be limited due to concerns about specific drug toxicity risk. And certainly lifestyle factors like smoking and exercise can be factors as well when we're met with our individual patient. What's become more apparent maybe over the last 5 or so years, reflecting a more refined approach to our practice and understanding our patient, is the concept of adherence. And we increasingly recognize how poor adherence may certainly be contributing to poor outcomes. But I suppose refractory RA is a component of this wider difficult to treat RA. And by this, like I said in the previous slide, indicates a patient that had needed a trial of multiple therapies, DMARD therapies, and that has failed to show efficacy to this. So if we focus on this definition, I suppose, I'd like to pose another question to you. In this context, what do you understand by refractory RA now? And I've listed here 6 options, and as you can see, they progress from conventional synthetic DMARD to the various classes of biologic and targeted synthetic therapies. So I'll give you a moment to complete that. Okay, so I suppose in the era of biologic therapies, initially refractory disease was reframed in the context of failure to TNF inhibitors, these being the first biologics to have been introduced. And this slide is essentially to illustrate what we've come to realize, that as our patients progress across the treatment pathway from an early RA stage and methotrexate naive to then being methotrexate experienced, in the TNF inhibitor category, we see then lower levels of response. And certainly we've recognized patients that are TNF refractory pretty soon after these drugs were introduced. So these weren't universally effective. But if we extend this concept, this next slide really is to illustrate how the emergence of new biologic and now targeted synthetic therapies means that the kind of patient we meet that's refractory continues to evolve as treatment options have become available. And so on certainly a pragmatic level, we understand refractory disease perhaps to be persistent, continued disease activity with limited remaining treatment options. And so we are certainly aware that some patients progress across these different treatments. So how much of a burden is refractory disease? Well, the caveat is that the definitions are quite varied, and I'll come on to that later, but certainly from observational and registry data, we have some insight into this. This first set of data is from Vienna, a single center cohort that aimed to look at its database from over 400 patients. It identified patients that it termed treatment amenable rheumatoid. So these were stable, responsive patients that were in sustained low disease activity or remission states. And then the refractory cohort, and here they define this as patients in moderate or high disease activity, again in a sustained state of this, with insufficient response to at least 3 DMARDs, including 1 biologic DMARD. So not necessarily multiple biologic failure, but at least 1 biologic. And we can see the proportion here, just under 20% fulfilling this category. This study looked at predictors of this refractory RA cohort, and there are factors, maybe generic factors that we've become conversant with, so delay to initial treatment, which we know is important for longer term outcomes, also female gender and higher disease activity. But interestingly, they found no significant difference in these factors, perhaps more objective factors we associate with disease between these 2 different treatment groups. There's similarly been another study by the British Registry, a biologic registry in rheumatoid arthritis, in the UK. And in this study looked at patients who'd started TNF inhibitors, and 1 in 20 patients was cycling through at least 2 biologic DMARDs within 10 years of treatment. The definition they employed here for refractory RA was exposure, not necessarily failure, exposure to at least 3 different classes of biologic DMARDs. And we can see here the reasons for failure were multiple. Most of the patients had a mixture of reasons, intolerance, inefficacy, but with a sizable proportion in whom repeated inefficacy was observed, up to 40%. And so 6% of adults with RA fulfill this definition, suggesting it's a modest group, but certainly we know refractory disease imposes a significant burden on the individual patient and, of course, on the healthcare systems. So these different definitions and increasing debate and awareness of refractory disease led the EULAR, so European League Against Rheumatism organization, to convene a task force to define difficult to treat rheumatoid. And again, this speaks to the interchangeability, I suppose, of difficult to treat and refractory rheumatoid disease. And in the task force, we agreed treatment failure to be defined as at least failure to at least 2 biologic or targeted synthetic DMARDs with a different mechanism of action. So not, for example, successive TNF inhibitor failure, with signs of active and or progressive disease. And you've got a list of what these are that we recognize in our clinical practice. What I put in italics here actually identifies an additional dimension of difficult to treat and speaks to maybe patients in whom obvious active disease isn't observed. So this is where there is well-controlled disease, but ongoing reduction in quality of life, and where the symptoms are perceived as challenging by the rheumatologist and or patient. And I'll come on to this a bit later and what perhaps this implies for how we define patients with refractory disease and stratify these patients. So I'm going to move on to a case study. This is patient A, who was double antibody positive, erosive, and had failed initial conventional synthetic DMARD, both methotrexate in combination with hydroxychloroquine. This patient initially had toxicity to a TNF inhibitor and was therefore given a trial of a second TNF inhibitor, to which they initially demonstrated a good response, but 9 to 12 months into that, lost this response, what we call a secondary or acquired non-response. They then went on to rituximab, which is often a sequence of treatment employed in the UK, but failed to derive a sufficiently effective response. This patient remained in moderate disease activity, and you can see the components here. So I'd like to go back to yourselves, the audience, and ask what would be your next choice? And I've put a few options here. I'll give you a few seconds to complete that. Okay, so this patient actually went on to receive an IL-6 targeted therapy, and I've highlighted here a trial by Alitaha et al. Called Surround-T of siricimab, an IL-6 monoclonal antibody, specifically in patients with active disease but refractory to anti-TNF therapy. And we've certainly seen an emergence over the last decade of studies now evaluating patients in this more resistant group. As you can see on the left here, these patients, large proportion, all patients had to have had previous anti-TNF, but the majority had failed anti-TNF due to inefficacy, with only a small proportion due to intolerance. A sizable proportion, almost 40%, had received at least 2 anti-TNF drugs. But as we can see, almost 40% had also received another non-TNF biologic DMARD. So these were quite a refractory proportion. And as you can see on the right, this is the ACR response outcomes. The primary outcome was ACR 20, but also 50 and 70 response included here compared to placebo with background conventional synthetic DMARD continued. And we can see that the primary endpoint was met with also significantly greater proportions achieving these high hurdle endpoints. So in a refractory cohort of TNF plus or minus other biologic DMARDs, we're seeing a benefit of this IL-6 targeted therapy. But a question that often is raised, and I alluded to when I spoke about the EULAR task force, is what do we actually mean by refractory RA from the physician's perspective and the patient's perspective? Certainly from the clinician's perspective, we assume this means ongoing active inflammation, as I said at the very beginning, persistent pathology that's resistant to multiple drugs. And by persistent pathology, we mean whether it's synovial disease, this being the primary manifestation of RA disease, but also not to forget RA is a systemic pathology, and so where there may be evidence of continued systemic inflammation. We use a composite index like DAS28 or equivalent to act as a surrogate for this inflammatory state, but we recognize this is imperfect. And so what we may be treating may not necessarily all be reversible. Certainly if there is development of damage that's driving components of the composite index, for example, the tender joint count and the visual analog score, and also therefore may not be fixable, where chronic pain and central sensitization may have set in. From the patient's perspective, arguably, refractory disease is more simplistically the persistence of symptoms and a poor quality of life, whatever the underlying etiology. And so this may not necessarily correlate with inflammation that we assign with being associated with poor outcomes, be it function, comorbidity, or mortality. And so one important aspect that I think we increasingly recognize that's not just limited to refractory RA are factors that drive our disease activity assessment, and therefore we need to take account into our decision making. So this study is again by the Vienna group that sought to look at patients who didn't achieve Boolean remission. So Boolean remission, as you know, is the most stringent way of assessing remission. And there are, out of the 4 criteria of swollen and tender joint counts, CRP, and patient global, they looked at patients who achieved 3 of the 4 and identified that 2/3 of those patients were failing to achieve Boolean because of not achieving the criterion patient global. And when looking at what was the most significant predictor of patient global, it was pain. So often patients are failing to achieve controlled disease, in this case remission, due to pain driving patient global. And this becomes important because when we assess our patients with ongoing disease activity, and particularly in the difficult to treat and refractory group who've had disease for a period of time, it remains really important to comprehensively assess our patients. So we use blood tests like CRP, X-rays, joint assessment, patient-reported outcomes, but also ultrasounds has become a valuable tool to be able to identify active inflammation where this may not be so apparent from our usual clinical assessment. So if we go back to one of my earlier slides of difficult to treat RA, including these whole host of components that can make treatment, disease assessment and treatment decision-making challenging, I would now perhaps divide refractory RA in terms of patients who've had multiple trials of therapy into those that have persistent inflammation and those that don't. And again, when we talk about true refractory disease, we're really speaking to those with persistent inflammation. And where I used to work in Leeds, we looked at this in our historical cohorts and found a sizable proportion had gone across that treatment pathway I showed you at the very beginning of failing almost all the classes of biologics and even JAK inhibitor. And when we used ultrasound in a prospective cohort to identify proportions of patients in whom there may not be inflammation, there was a reasonable proportion that was satisfying this group. So it's important that we use all our tools available to really be able to stratify patients that have refractory disease. But why may it be that patients have persistent pathology in the face of such effective targeted therapies? And this is clearly not been elucidated. And what's also not clear is whether sequence of therapies is relevant. I'm not going to focus on that, but it is a research question maybe. What we understand about rheumatoid is that it's highly heterogeneous, that patients span across the innate and adaptive pathways. And so there may be either targets that are relevant in subgroups that clinical trials haven't identified and confirmed, or indeed some unidentified targets of disease. So moving on to a next case study, this is a 48-year-old lady who has antibody negative disease, non-erosive at the time of diagnosis, but had an incidental MPOP ANCA with no associated clinical phenotype, had again failed conventional synthetic, had persistently high disease activity. And you can see the biologic DMARDs this patient had gone through, etanercept, and then rituximab and certolizumab, to which anaphylaxis had been shown. This patient then went on to sarilumab, similar to the study I showed about the benefit of IL-6 targeted therapy, and showed an initial response, but then developed an acquired non-response and had active disease and, interestingly, more swollen joints compared to tender joints, with evidence of low complements and lymphopenia. So a bit of a mixed phenotype, speaking to the heterogeneity of disease. So this is your next question. What would be your next choice? And I've put these options here, and I'll give you a moment to complete this. Okay, so this patient actually went on to have a JAK inhibitor, and these have emerged as our newest class of therapy, the small molecule inhibitors that target the JAK-STAT pathway. And as you know, the JAK-STAT pathway facilitates a series of phosphorylation steps and enables the signaling of a multitude of cytokines. And I've highlighted ones here that particularly have been implicated in RA pathogenesis. And there may be an argument that this greater coverage of multiple cytokines, as opposed to, say, the monoclonal antibodies that target single cytokines, may afford a greater efficacy. And that might be relevant in patients with refractory disease. We recognize from the various JAK inhibitor trials, and these are not to compare as I've highlighted, but they have shown efficacy in patients with rheumatoid, and increasingly we see comparative groups, typically with a TNF inhibitor, and where JAK inhibitors have been shown to at least be equivalent, if not superior, including for quite high hurdle endpoints. But even trials have appeared in more refractory disease. This is just by way of example, Finch 2, looking at filgotinib as preferential JAK1 inhibitor. And again, in a refractory cohort, as is included here in this table showing the characteristics of patients that have failed multiple biologics, mainly lack of efficacy, and achieving the primary endpoint of ACR20, and also the high hurdle endpoints, as also demonstrated here by DAS28 CRP of less than 3.2 and 2.6. And similarly, we can look at the trial Select Choice that looked at upadacitinib, another JAK1 JAK inhibitor. And this again was in patients that had failed previous biologic DMARDs, a sizable proportion failing several. And this confirmed non-inferiority as the primary endpoint, but also superiority. although upadacitinib was shown compared to abatacept, which was the active comparator arm, to be associated with more serious adverse events. And so when we start looking at our patients that have co-multimorbidity, it is a balance between trying to achieve greater efficacy in patients who've had prior treatment experience with also potential concerns about toxicity. And it's an integration of these that we include. So the patient I was talking about before received baricitinib and had an evidence of a clear initial response, but then again lost this and had clearly active disease. And now we saw emergence of erosions on ultrasound over this intervening period. And so there are various options we could consider, and I've listed them here. What we actually decided was to switch within JAKs because she'd shown a very good response to baricitinib, and so we switched to tofacitinib, which was the other JAK inhibitor available, more for a pan-JAK inhibitor. But this patient failed to show a really good, meaningful response, and in essence needed to maintain sizable doses of steroids. And so the current status is included here, quite bulky active disease, lymphopenia, that MPOP anchor is again positive. And so essentially we have very limited treatment option. And so we're planning for abatacept, but to highlight this patient has now ongoing disease activity. There's infection concern, as there has been by this lymphopenia, and very limited treatment options. And so it's taking precautions in the face of active disease that clearly needs to be treated, but to try and minimize infection risk. And I've listed this here. So, I mean, I've spoken about the need to clearly control disease, and we're all conversant with the concept of treat to target. But this slide is really just to highlight that our triggers for treatment change and how we assess risk-benefit of our patient really evolves. And I think we're probably aware of that with our individual patients, but this is really to articulate it. The drug response falls within a spectrum, and that failure of drugs is rarely absolute, as I've maybe illustrated through some of the cases. What constitutes an acceptable disease target may change over time, and the prior treatment history and treatment options is clearly relevant. What I often find with my patients is that the burden of disease is often less once they've entered the framework and the era of biologic and advanced therapies. And so the management of difficult to treat is really an integration of these components, and we're constantly incorporating this to decide when is the appropriate time to cycle, which may change over time. And we may indeed take on greater risk when treatment options are that much more limited. So I'll draw this almost towards a close, just to highlight this point by this case study of a patient with active disease who'd failed all biologic DMARD classes, who'd also was then on a JAK inhibitor, and who had some ongoing active disease, but this was following a period of having been off treatment for intercurrent infection. And it was difficult to assess their disease because of chronic change, but ultrasound clarified there was an element of power Doppler. But this is the quote from the patient, but that the arthritis was way worse years back before they went on their biologic drugs, but the patient was still getting a lot of pain. And so these are the kinds of questions that we consider. Should we switch therapy? There's very few treatment options now. Should we wait until it's more active, or should we reassess in a few weeks' time to see if there's still active disease and whether that intercurrent infection was at play? And we've gone for that last approach in light of the limited treatment options. So I'll just highlight this, that we're aware of trying to change the trajectory through early intervention and responsive treatment escalation. But the fact we still see difficult to treat and refractory RA suggests that we may be failing to treat disease effectively from the outset. And this is something we need to consider. And so I'll draw the talk to a close by maybe summarizing that the reasons for difficult to treat RA and the refractory RA and this gap in effective response are multiple. It's still a pertinent issue, even in the era of advanced therapies and highly effective targeted therapies. The accrual of secondary features such as osteoarthritis damage and central sensitization can complicate our assessment, and certainly that might be leading to some unnecessary cycling in a proportion. This emphasizes the need to use all tools, for example, ultrasound, to clarify the extent of active disease. Certainly comorbidity and toxicity concern can limit our cycling options. It remains important to have really effective early strategies to mitigate against future development of refractory RA, and certainly the emergence of new therapeutics may provide greater coverage of disease in our patients that are refractory. But that final point, that the target of treatment and our risk assessment evolves within a patient over time. And certainly when we have patients that are refractory, it makes us think harder about when and how we should be switching drugs. So I'll leave it there and thank you for your attention and we'll be pleased to answer any questions. Thank you.